Good afternoon to everyone that just joined us. My name is Susana Molina, and it is my pleasure to welcome you to AHPA's webinar on the OPPS and PFS proposed rules for calendar year 2023. If you have any questions as we're going through the presentation, please include them in the chat box and we will address them at the end of this presentation. This webinar is being hosted by the Adventist Health Policy Association, which is the policy voice for 5 7-day Adventist affiliated health systems, including Advent Health, Adventist Healthcare, Loma Linda University, Kettering Health Network, and Adventist Health. Today, you will be hearing from our public policy team, which includes myself, Sherry Danielson, Marisa Lopez, and Brandon Cook. We'll be covering key policies, including in the OPPS and PFS proposed rules. As a reminder, the OPPS rule sets payments for outpatient services, and the physician fee schedule rule sets payments for physician services. The rules are expected to be finalized at the end of November or beginning of December, and they become effective on January 1st of 2023. I remind everyone that all of these are in proposed form, so the policies discussed today may change in the final rules. These are the topics that we'll be covering in today's presentation related to the OPPS rule. And these are some of the key highlights. As in previous rules, we're seeing a continued shift to the outpatient care, even though this administration is less aggressive than the previous one when it came to accelerating that shift to the outpatient setting. We're still seeing more proposals to remove services from the inpatient-only list. In fact, 10 services are proposed for removal, and CMS is also proposing to add one more service to the ambulatory surgical center cover list. We are seeing also more containment strategies. In the Trump administration, CMS adopted for the very first time in Medicare fee-for-service prior authorization. And in this rule, they're expanding upon that policy by proposing a new service category that would be subject to prior authorization. To us, this indicates that this is a tool that will continue to increasingly be used in the fee-for-service program, and we know that Congress is looking at potential changes in Medicare Advantage also related to prior authorization. Several policies to increase access in Medicare. This is an example. CMS is proposing to extend the supervision authority for the performance of diagnostic services to non-physician practitioners so that they can supervise those services either direct or through personal supervision. There are also several policies aimed to support financially rural hospitals. The first policy implements requirements related to emergency hospitals, and then the second exempts rural small community hospitals from site-neutral payment policies that were adopted in the past. We're also seeing an increased emphasis to increase access to behavioral health services. As you can see here, CMS is making telemental health service a covered outpatient service when provided in the patient's home. And then there are several requests for information in the rule, but I want to particularly flag this one for you. In last year, President Biden signed an executive order instructing HHS to develop policies aimed at increasing competition in healthcare. So in this rule, they're asking comments on what type of data could they require different providers to submit and then share with the rest of the public to better assess the impact of hospital mergers, acquisitions, and consolidations. So we know that this is the beginning of more to come related to increasing competition in the marketplace. And they will be focusing on first gathering data and then making that data public for researchers to review and then determine what is the impact on hospital consolidation. Next slide, please. And this is the proposed payment increase for outpatient services. CMS is proposing to increase outpatient services by 2.7% and by 2.7% for ambulatory surgical centers. In our comments to CMS, we are going to, again, highlight that this increase does not really capture the current inflation rate or the increased labor costs that are experienced by healthcare providers across the United States. We, in the inpatient prospective final rule, CMS did ended up increasing their original payment rate. So we are hopeful that they will do the same with this rule, but nothing is ever certain with the federal government, as many of you know. Now moving on to rural emergency hospitals. Before we look at the proposed policies, I want to take a second to look at this map. As you can see here, between 2017 and 2022, about 66 rural hospitals closed in the United States. And many of those closures impacted AHPA states. As you can see here, pretty much every AHPA state has been impacted by rural hospital closures. Of those closures, 29 were hospitals paid under the prospective payment system, 19 were critical access hospitals, 14 were Medicare dependent hospitals, and 4 were sole community hospitals. Now, when we look at a wider period, beginning in 2010, you can see that the closures are all over the map. In 2020 alone, a total of 19 hospitals even closed across the country. 44 of those hospitals were critical access hospitals. When you look at this map, you will notice also that the states of Texas, Florida, and Kansas, which are states served by Advent Health, have been particularly impacted by this trend. And California as well has been heavily impacted. But particularly Texas, I just want you to look at all those closures in the state of Texas. So this is a trend that policymakers are keenly aware of and that they want to address. Because of this, in 2021, Congress created a new hospital designation called the Rural Emergency Hospital Designation. This designation is only available to existing rural hospitals and critical access hospitals that have less than 50 beds. Those hospitals would receive an added 5% increase over every outpatient service they provide, and they would also receive a monthly facility fee, which is outlined at the end of this box on your left. Now, the caveat with this designation is that in order to be eligible for it, the hospital cannot offer inpatient care. The maximum length of stay, therefore, cannot exceed 24 hours. Also, there has to be a state license available for hospitals to be able to operate under this new designation. And we know that not all states have already gone through the state legislature to create this new hospital license. There are a couple of things that we are concerned or have questions about that we plan on raising on our comments to CMS. The first one is whether these new hospitals will be eligible for 340B discounts. As many of you know, under the 340B statute, this is not considered an eligible entity because it is a new designation. So we don't know if CMS has the authority to be able to change that and say that these new facilities will be eligible for the discount, or if that has to go through, there has to be some sort of congressional action taking place for that to happen. The other concern that we have is that if too many hospitals shift to this new designation, there may be communities that will lose access to that timely inpatient care. So we are planning on recommending to CMS to make some sort of exceptions depending on the population, and particularly if there is not another hospital that provides inpatient care within 30 miles of the rural emergency hospital. We don't want patients having to travel a significantly long distance to be able to access those inpatient services. And then the third concern that we have is that many of our AHPA critical access hospitals were able to qualify as critical access hospitals under previous eligibility rules that have currently been changed by Congress. So if they were to apply for this designation and then things don't work out and they want to shift back to that critical access hospital designation, they may no longer be eligible. So we are providing a recommendation to CMS to allow for those CHAs that to shift back to their critical access hospital status if they held that in the past, regardless of whether they are eligible today or not.
So now we can move on to some of the policies proposed for the 340B program. And just to give a brief overview about what's been happening. So in 2017, CMS cut payment rates for 340B drugs by almost 30%. This caused several hospitals, including some AHPA member hospitals, to file lawsuits and argue that CMS did not have the authority to do this. These cases have worked their way through the federal district courts and appeal courts, first the courts agreeing with hospitals and then overturning that decision. As this was happening, CMS implemented even steeper payment reductions. They launched a survey to determine hospital costs for 340B purchases. This type of survey is actually required before CMS makes those fiscal policy changes like these. However, in 2022, the Supreme Court said that because the survey was done after the fact, CMS's cuts for 340B drugs were not done within its statutory authority and ultimately sided with the hospitals. Immediately after this decision was made, hospital groups petitioned the courts to reinstate the original 340B payment rates for the rest of 2022 and to be retroactively compensated for the 340B cuts between 2018 and 2022. In response, HHS asked the courts to allow reversing those payment cuts through this OPPS rulemaking process as it's currently underway. HHS also said that it has multiple approaches to undo the cuts, including potentially paying 340B hospitals prospectively to make up for the cuts and putting out a survey on 340B hospital drug acquisition costs to see whether repaying hospitals is even necessary. Some things to keep in mind is that the funds from the 340B cuts have already been distributed in previous rules, and it was done in a budget neutral manner. This means that the money saved from previous year's cuts was distributed in other areas, such as raising payment rates for other services. And it could potentially mean that if CMS reinstates the 340B payment rate, it will lower rates in other areas of the OPPS rule. AHPA is advocating that CMS get rid of the 340B payment cuts without lowering rates in other areas of the rule. Now moving on to organ acquisition payments. So in 2022, CMS proposed to revise Medicare's usable organ policy to count only organs transplanted into Medicare beneficiaries in transplant hospitals and organ procurement organizations, or OPOs. However, CMS did not finalize this proposal due to a number of comments expressing concern over potential operational challenges and increases in burden from tracking organs from donors to recipients. Another concern was the resulting revenue reductions, particularly for children's hospitals, which have a very low Medicare utilization. CMS said that they would conduct further analysis, but would consider this proposal in future rulemaking. In this year's proposed rule, CMS is seeking information to consider an alternative methodology that would report organs transplanted into Medicare beneficiaries in order to calculate Medicare's share of organ acquisition costs. This means that providers would not have to track organs that are transplanted into Medicare beneficiaries at other hospitals, but would have to track what is transplanted into beneficiaries at their own hospital. CMS believes that since transplant hospitals and OPOs would not have to track organs going to non-Medicare beneficiaries, they would not there would not be a large burden on providers. The RFI also asks if children's hospitals should be treated differently under an alternative organ counting methodology due to their lack of Medicare patients. CMS seems very intent on finding a way only to pay for organs going specifically to Medicare beneficiaries as a cost-cutting measure. If anyone wants more information on this, we do have a summary of the RFI that we would be happy to share. And I also wanted to note that Congress has been looking into the National Organ Network Organization, also known as UNOS, and the many flaws there are with the current system. In a recent Senate Finance hearing, UNOS was slammed over its inefficiencies in transporting and tracking organs, which has led to a lot of waste of otherwise healthy organs. While it seems like CMS is looking for a way to account for the organs for Medicare beneficiaries, they're also aware of the many issues providers have been having with tracking in the current system.
The proposed rule also has changes to the prior authorization process in fee-for-service Medicare. And as Susanna mentioned, this is really a bipartisan priority. The previous administration really laid the groundwork here with significant focus on reducing fraud, waste, and abuse within Medicare. And this spring, you may remember that the Department of Justice had an investigation into about $250 million of potentially fraudulent payments. So we are continuing to see these additions to prior auth as a way to reduce potential fraud and waste. In this year's rule, CMS is proposing to add one new service category, facet joint interventions, to the prior authorization list. This new category is made up of facet joint interventions, nerve destruction, and medial branch nerve blocks, and would include the CBT codes that you see listed on the left of the slide. And then finally, we do want to emphasize that there is a proposed change in the effective date for prior authorization policies from July 1st, like we're used to an earlier March 1st. We also see changes to telebehavioral health care. During the public health emergency, CMS extended us significant flexibilities for our providers to be reimbursed for giving telehealth services to patients while patients are in their own homes. But these flexibilities were scheduled to end with the expiration of the PHE. Multiple times during last regulatory season, AHPA and some of our colleagues all advocated for the preservation of these flexibilities. And as a result, CMS is now proposing to preserve access to mental health care at home by creating 3 new HCPCS codes that would cover behavioral health care for beneficiaries even when they are in their home. CMS uses the inpatient-only list and the ambulatory surgical center list to regulate the site of service for various healthcare procedures. Inclusion or omission is determined by many factors, including patient safety, quality of care, and cost. Just like we saw in last year's rule, CMS is continuing building that momentum behind services being done outpatient wherever is clinically appropriate. There's only one addition to the ASC covered procedures list this year: lymph node biopsy or excision. But the agency does propose some significant removals from the IPO list this year, with 10 more services being taken off the list. And just as a quick reminder, the IPO list is CMS's way of saying, hold on, the only way that these can be done safely are if they are in the inpatient setting. So if any of these 10 services are removed from the IPO list, it just means that CMS now believes that they can be done safely either inpatient or outpatient, however the provider deems clinically appropriate. And additionally, upon clinical review, CMS is proposing to add the 8 newly created CPT codes that have to do with hernia repair, total disc arthroplasty, mesh implantation for declayed closure defects for CY23 to the list of inpatient-only procedures.
So moving on and looking at the outpatient and the ASC quality reporting programs. Typically, these programs do not overlap. However, in this rule, we are seeing the same proposals. For an overview, this is a pay-for-performance program in which hospitals must meet the quality reporting requirements or they receive a reduction of 2 percentage points in their annual payment update. So we're not seeing much movement in the QRP this year. CMS is not proposing to adopt or remove any quality measures. However, they are looking at making modifications to the cataracts, improvements in patients' visual function within 90 days following cataract surgery measure. CMS proposes to allow for voluntary rather than mandatory reporting for this measure, beginning with the calendar year 2027 payment determination or the calendar year 2025 reporting period. CMS noted concerns about the reporting burden of this issue in light of the national staffing and medical supply shortage, as well as changes in patient case volume caused by the COVID-19 public health emergency. CMS is also seeking feedback on the future re-implementation of the hospital outpatient volume on selected outpatient surgical procedures measure within the outpatient QRP. And what CMS is looking to see if whether this measure should be readopted to the program, or if there are any other indicators that would be more appropriate as a quality measure in this program. Lastly, to close out the OPP portion of this PowerPoint, and as Susanna mentioned earlier, there was that request for information over mergers and acquisitions. CMS is requesting information on the potential use of CMS data to drive competition and protect the public from the harmful effects of consolidation within the healthcare marketplace. CMS believes that its past efforts at publicizing data and requiring price and cost transparency can be used to increase marketplace competition. So therefore, CMS is seeking feedback on additional data that would be helpful in pursuing transparency efforts. AHPA believes that the interest we're seeing now in hospital mergers and acquisitions is just the beginning. CMS noted that the purpose of this RFI was to comply with President Biden's executive order on promoting competition in the American economy, which called for a whole of government approach to address excessive concentration, abuse of market power, unfair competition, and the effects of monopolies. The leaders of both HHS and CMS are interested in being more involved in the future monitoring of hospital consolidation. So an important policy insight, if a facility or provider is looking at acquisitions or mergers, focusing on how this will increase access for patients while also lowering costs will be important because there will be that increased scrutiny.
Moving on to the physician fee schedule, these are the topics that our team will be covering in the next few minutes. And these are some of the highlights. This one was a little bit hard to, this was a hard slide to work on because there are so many different important highlights within this rule that is much more dense than the OPPS proposed rule. The first one relates to the merit-based incentive payment system. CMS is expanding the value pathways. They're adding 5 new value pathways. And when you think about the merit value pathways, these are kind of like quality lanes that clinicians can choose from depending on their specialty, so that when they report quality measures, they're not just reporting quality measures that may impact everyone, but they are also reporting quality measures specific to their specialty. In 2026, CMS is adding another layer of reporting so that multi-specialty groups would be required to participate as subgroups within MVPs, and they will be required to describe the composition of those subgroups. CMS is also proposing several changes to the Medicare Shared Savings Program. From the most part, what we're hearing is that these are positive changes. They're providing advanced payments to ACOs that are low revenue and serve underserved populations. They're also allowing new ACOs to remain under one-sided risk for up to 7 years. And they're adopting a new health equity adjustment to incentivize excellent care for ACOs serving underserved populations. As in any rule released this year and the past year by the administration, there's a significant focus on health equity. CMS is proposing to include 2 measures related to social determinants of health in the future in the APM performance pathway. One of them relates to screening for social determinants of health, and the other is the proportion of patients that test positive to one of the needs of theirs that they are surveyed for. They're also proposing more improvement activities related to health equity that Cherie Danielson will be covering in more detail. Last year, CMS created a whole new category called health equity under their improvement activities. And all these new health equity measures are being weighted highly so that they have more impact on our clinician score. And we expect more and more health equity measures to be incorporated, not only in the physician fee quality programs, but also across the continuum of care. We've already seen some, like those two SDOH measures being finalized in the inpatient prospective payment system rule. Now they're being proposed for the physician fee schedule rule. We expect their incorporation potentially in other settings of care. There are also a couple of policies related to telehealth. CMS is reminding all providers, which we all very keenly are aware of, that the telehealth flexibilities will end 151 days after the public health emergency ends. They're also proposing to add 53 new Category 3 services to the telehealth list. These are temporary services. Unfortunately, CMS is only proposing to cover them for 1 year. CMS is also proposing to add a couple of permanent codes for prolonged services that are set to replace existing codes. And then the positive thing, they are delaying in-person requirements for the behavioral health services, provided via telehealth. In addition to that, there are other policies to increase access to behavioral health, and these two are just examples of that. The rule is proposing to reduce the conversion factor for the physician fee schedule from $34 in calendar year 2022 to $33 in calendar year 23. This represents a 4.4% cut approximately. For those of you that are not familiar with this policy, the reason why CMS is implementing these payment cuts is because in 2020, they increased payments for evaluation and management services. And the Medicare statute requires that every time CMS increases payments in one area, they have to decrease the same amount in another area. In order not to choose winners and losers, CMS went ahead and just reduced payments across the entire physician fee schedule by simply reducing the conversion factor. Last year, Congress tried to mitigate the impact of these codes by increasing the factor by 3%, but that increase expires at the end of this year. AHPA is strongly advocating for Congress to again provide any type of relief to physicians, and we're working with American Hospital Association, the AAMC, and others to make this happen. We're hearing mixed messages. Some say that it's likely to happen, others say that they may not be able to do 3%, they may be able to do a 2.5%. Again, there's no certainty behind this. Most specialties will also see an estimated negative 2% or positive 2% impact to their payment changes, mostly related to changes that CMS made in the rule related to relative value units. And this table summarizes the greatest positive and adverse impacts to specialties based on those relative value unit changes that CMS made in the rule. As you can see here, those specializing in infectious disease will see approximately a 5% increase, whereas those within interventional radiology will probably get the highest cut of about 4%. This table also does not capture the impact of the reduced conversion factor. So if you add the conversion factor reduction, these specialties are seeing significant payment cuts. If you're interested in seeing the full list of the impacts to specialties, we encourage you to look at table 138 and 139 of the rules. Feel free to send us a message if you want, and we can also send you the copy of the tables.
CMS is proposing updates to both arms of PFS's quality payment program. The quality payment program seeks to high-value care through the Merit-Based Incentive Payment System, or MIPS, and Advanced Alternative Payment Models, or APMs. And within the QPP, this is where you're going to see those health equity measures, as well as increased priority of all health equity measures that Susanna was just mentioning in her key highlights. So first, we'll look at MIPS. MIPS, or the Merit-Based Incentive Payment System, is one of two tracks housed within the QPP. Its goal is to migrate Medicare Part B providers into that performance-based payment system. Opting into MIPS comes with data reporting requirements, performance feedback, and a MIPS payment adjustment based on that performance. Participant performance in MIPS is measured across 4 categories: promoting interoperability, quality, cost, and improvement activities. This year, CMS is not proposing any changes to the weights of these categories, and the agency will continue its policy of automatically reweighting the improvement activities domain for those of us with smaller practices. Within these 4 domains, the majority of the proposed changes this year center around improvement activities and promoting interoperability. And in the quality domain, CMS is proposing to designate any measure that has to do with health equity as high priority, and is open to any feedback on the best ways that it can measure health equity overall within MIPS. We can go to the next slide on that one, thanks. So CMS is proposing to add 4 and remove 5 improvement activities from the MVP, or MIPS value pathway inventory. All 4 of the new activities that you see in the green box are directly aligned with CMS's 6 health equity priorities for reducing disparities in health. Modifications that you'll see in the removals are intended to update the MIPS MVP inventory for alignment with current clinical best practices, and CMS has received feedback over the last few regulatory seasons that many of these are duplicative, antiquated, or unduly burdensome. The agency is also proposing changes to the Promoting Interoperability program. If you joined us for our IPPS proposed rule webinar, then this will look very familiar. Many of these changes are directly in alignment with the inpatient PI proposals that we saw this year. First, under the e-prescribing objective, CMS is proposing to make the query of the PDMP measure mandatory for 10 points. And this would also be expanded to include Schedule 3 and Schedule 4 drugs. And then under Health Information Exchange, CMS is proposing to add a new measure, a new objective rather, or measure, the enabling exchange under the Trusted Exchange Framework or Common Agreement, what we call TEFCA, as an option. And this would require a yes/no attestation. So participants could choose between either of these 3 to earn that total of 30 points under this domain. This does not change the total points possible. It is still out of 100. As finalized last regulatory season, CMS will make its MIPS value pathways, or MVPs, available for reporting gradually, beginning with the 2023 performance year. The agency proposes 5 new MVPs for reporting that year, and these would join the 7 already existing ones finalized in last year's rule. There are some additional proposed changes as well. The agency proposes to maintain the 75-point penalty avoidance threshold, establish a maximum cost improvement score of 1 percentage point in the cost performance category, add a 3rd requirement to the subgroup registration, and allow a clinician to register for 1 subgroup per TIN.
So looking at the Medicare Shared Savings Program, for a quick overview, this is a voluntary alternative payment model that gives providers the opportunity to create their own accountable care organization and take part in earning bonuses through shared savings. We are seeing a lot of proposed changes to the MSSP this year. The reasons is that CMS is looking to ensure that they're making new policy adjustments to attract new participants, sustain the program, and incorporate health equity principles. CMS also expressed their concern about the stagnation of the program and the underrepresentation of minority groups. It's worth noting that the changes proposed this year are meant to set the program up to meet CMS's future goal of moving all Medicare beneficiaries to an accountable model by 2030. This will be a high-level overview of this program, so feel free to email us if you have any questions or put in the chat box. So looking at advanced investment payments, Like I mentioned earlier, that CMS is looking at how to entice new participants in the program. And one area that CMS identified as a roadblock to participation is the high upfront cost that is required for an ACO to be successful. To remedy this, CMS is proposing to disperse advance investment payments to incentivize new ACOs into joining. Eligible ACOs would receive a one-time fixed payment of $250,000 and 8 quarterly payments based on the needs of their beneficiaries. The amount of the quarterly payments will be based on the number of assigned beneficiaries and a risk-based score, which is calculated on the beneficiary dual eligibility or the new area deprivation index, the ADI. To be eligible, ACOs must be new, not re-entering or renewing. They must qualify as low revenue, and they must be inexperienced with performance-based risk. AHPA intends to advocate for CMS to expand the eligibility requirements to ACOs that do not qualify as low revenue, as this may unintendedly exclude ACOs that are not by definition low revenue, but they serve underserved populations. While high revenue ACOs may have more resources, the advanced payments could be utilized to incentivize further investment in health equity initiatives. And lastly, CMS is planning on recouping the advanced investment payments from the shared savings earned by an ACO. However, if an ACO does not achieve savings, the recoupment will carry over to the next year. Looking at the transition to two-sided risk, CMS is proposing to alter the pathway to success model, which set a very concrete roadmap for ACOs to transition to two-sided risk within 2 years of joining the program. Now, CMS is proposing to allow ACOs that are at present participating in one-sided risk to remain at their current level for the remainder of their agreement. Additionally, new ACOs that are inexperienced with risk who are entering into the program for their first agreement will be allowed to stay at level A risk for the entire 5 years of their agreement period, and this would begin in January of 2024. Another proposal from CMS is to allow ACOs to participate in the basic track glide path for a maximum of 2 agreement periods, beginning at level A risk for the first agreement and then progressing into the glide path for the second agreement, meaning that new ACOs could receive the first 5 years at no risk and then the first 2 years of the second agreement at no risk for a total of 7 years. Lastly, if an ACO is entering in the program at level E, CMS is proposing to allow them to remain there indefinitely. CMS is continuing with its goal to transition to electronic reporting, and starting in 2025, CMS will make the full transition by requiring the reporting of 3 ECQMs and doing away with the web interface. However, CMS is looking at ways to make the transition easier and allowing more time for organizations to prepare. In this rule, CMS is proposing to continue last year's proposal of incentivizing ACOs to transition early to ECQM reporting by providing an alternate path to achieving compliance, which would consist of an ACO that reported all 3 ECQMs, achieves the 10th percentile on one outcome measure, and the 30th percentile on one of the remaining 5 measures. They will have satisfied the standard. This year, CMS is proposing to continue this policy and would update the requirements to match the 40th percentile scoring requirement for performance year 2024. CMS has also requested comment on dropping the requirement that an ACO meet the 30th or 40th percentile on one remaining measure if it finalizes the policy. Next, we have the new health equity adjustment. If an ACO is qualified, this proposal would add points to their quality score, and this would be incorporated in performance year 2023. The health equity adjustment will be based on the quality performance and the share of an ACO's beneficiaries that are underserved. And this would be calculated again with the dual eligibility status or the area deprivation index. The health equity adjustment will add a maximum of 10 points to the quality score. To qualify, an ACO will need to report 3 ECQMs, meet the completeness requirements, and fill the CCAPS for MIP surveys. There are concerns about the requirement of submitting 3 ECQMs. This is one way in which CMS is trying to entice ACOs to transition to the ECQM reporting before the 2025 deadline. However, very few ACOs actually submitted 3 ECQMs in 2021. So the concern is that there are many ACOs that will not qualify for the health equity adjustment, and that the eligibility requirements will undercut CMS's goal of advancing health equity. Another proposal from CMS is to increase the opportunity for low revenue ACOs to achieve shared savings. If an ACO is in the basic track and misses the minimum saving rate requirement, but they do meet the quality performance standard, CMS is proposing to qualify that ACO for partial shared savings, meaning they would receive half of the maximum shared rate. For benchmark improvement, CMS is looking to reduce the effects of an ACO's performance on historical benchmarks and to increase options for ACOs caring for high-risk populations. Proposals include reducing the impact of the negative regional adjustment and incorporating prior saving adjustment into historical benchmark for renewing or re-entering ACOs. And lastly, for the MSSP, CMS is looking at how to streamline the program and reduce the regulatory burden on ACOs. Changes here would include eliminating the marketing material requirement that an ACO must submit for review and reducing the beneficiary information requirement notices and streamlining the process for an ACO to request a SNF 3-day rule. Moving on to the split or shared EM, we're not seeing a lot of proposals out of here. However, back in 2022, CMS finalized a policy where a physician or non-physician practitioner who performed a substantive portion of the visit will therefore billed for the visit, and they defined a substantive portion being more than half of the total time. However, in this rule for calendar year 2023, CMS is looking at delaying the new definition, or delaying the implementation of this definition of substantive portion until 2024. Okay, and looking at telehealth, CMS is proposing to adopt 53 services into the Category 3 temporary basis. But like Susanna mentioned earlier, the Category 3 basis is not tethered to the public health emergency and is set to expire at the end of calendar 2023. In accordance with the Consolidated Appropriations Act, CMS will extend certain telehealth flexibilities for 151 days after the conclusion of the public health emergency. And during this 151-day period, physicians will be required to use modifier 95. On the 152nd day after the end of the public health emergency, all of the telehealth policies will revert back to the pre-public health emergency policies.
Next, we will cover the proposals that are expanding the scope of practice for some non-physician practitioners. During the COVID-19 pandemic, CMS allowed the supervision of diagnostic tests by certain NPPs to alleviate clinical staff shortages. And in this year's rule, CMS is proposing to make permanent this practice. Next slide, please. And now we'll talk a bit about behavioral health services. But before we dive into the policies being proposed, I want us to look at the current state of behavioral health in the United States. There's always been a high need for behavioral health services. In a typical year, 1 in 5 adults will experience a mental illness, and 1 in 8 adults will need to be treated for a substance use disorder. Despite there being a high demand for behavioral health services, 122 million Americans, or approximately 37% of the US population, live in a mental health professional shortage area. Provider shortages also get worse in rural areas, with half of the non-metropolitan counties lacking a psychiatrist or a psychologist. The COVID-19 pandemic worsened the state of behavioral health in the United States. In 2020, the number of reported depressive or anxiety disorders increased by 27%. Among teens and young adults, there was a 31% increase in psychiatric-related hospital visits throughout the pandemic. In addition to growing mental health illness, substance use disorders worsened as well. From April of 2020 to April 2021, there was approximately 100,000 deaths related to drug overdoses. Behavioral health has become a bigger priority for federal agencies as the need for services has grown. Earlier this year, CMS released their strategy to address behavioral health. This includes developing more quality metrics, which falls under that strength and quality and equity category, and utilizing more data tools such as the Mapping Medicare Disparity tool that can help identify areas of disparities between Medicare beneficiaries. In this year's rule, CMS is trying to address the shortage of behavioral health providers by allowing behavioral health services to be provided under general supervision of a physician or MPP, as opposed to the direct supervision whenever these services are being provided by an auxiliary personnel, such as a licensed professional counselor or a licensed marriage and family therapist. CMS has also been creating new codes for behavioral health services for the past few years. Last year, they implemented codes to expand telehealth for behavioral health care. This year, CMS is creating a new code for services furnished under the psychiatric collaborative care model, which aims to integrate behavioral health and general medical services. This code would account for the mental health services furnished by a clinical psychologist or clinical social worker in an integrated care setting. And finally, we'll cover some of the proposals addressing the opioid treatment programs, or OPTs. CMS is working to strengthen their OPTs by providing more flexibility in furnishing services. CMS is allowing OTP intake add-on codes to include two-way audio-video calls. CMS is also increasing the time for a base rate of individual therapy to 45 minutes. CMS is choosing to do so because they are recognizing that some of the therapy visits take longer than the current 30-minute time frame, particularly during medication-assisted treatments or other treatments for opioid use disorders. And finally, CMS is updating the methodology for pricing the drug component of methadone weekly bundles and add-on codes for take-home supplies. Methadone is a drug used to treat chronic pain or opioid dependence. The old method-based payment rates on average sales price, with the inclusion of the newly reported methadone tablets, caused significant decreases in average sale prices. Therefore, CMS is proposing that the drug component of the HCPCS code will be based on the payment amount for the methadone in 2021 and updated annually to account for inflation. And this would prevent those payment rates for methadone to fall. And that concludes our proposed policies in this year's PFS proposed rule. If you have any questions, now is the time to unmute your line or enter your questions in the chat box.
Good afternoon. This is Carlisle Walton, and for those who do not know me, I've been privileged to lead AHPA for the past 4 years and work with what I consider the best federal policy team in the business. So Susanna, Cherie, Brandon, and Marissa, thank you for another well-prepared and presented webinar. And a big thank you to all the participants for your engagement with AHPA, and I encourage your continued engagement. Thank you so much.
Thank you so much, Carla. We appreciate it. Any questions, thoughts? All right, wonderful. We'll give everyone back 10 minutes. Have a great weekend, and thank you so much for your time and joining us.